Good day, I'm an infectious disease fellow and I'm here to discuss about antimicrobial stewardship. The next slide will show you a video clip of a short background on the topic.
Hi there. Did you know that 70 years ago, penicillin saved countless lives in World War II? Fast forward to the 21st century, and the chief doctor in the UK calls for antimicrobial resistance to be put on the National Risk Register and be taken seriously. And the US government describes antimicrobial resistance as one of our most serious health threats. In Canada, outbreaks of superbugs frequently make headlines because they kill patients. Antimicrobial resistance isn't a new phenomenon. All germs have the ability to develop resistance. But the more drug exposure there is, the faster resistance develops in people, animals, and agriculture. We now face infections that are resistant to many, if not all, of our available drugs, and there is very little to look forward to in the antibiotic development pipeline. Since 2010, only 3 new antimicrobials have been approved for use in Canada. This means that we must manage these precious resources more wisely, like preserving clean drinking water or halting global warming. Inappropriate or unnecessary use of antimicrobials is often cited as up to 50%. Misuse of antimicrobials is risky to patients. It can increase mortality, time spent in hospital, and lead to collateral damage, such as a new infection with another bug, like C. difficile, a germ that causes diarrhea in most but may cause serious or fatal infection in others. Using antimicrobials appropriately will not only help preserve our antibiotics, but will also improve patient outcomes and patient safety. Everyone wants to do the best thing for their patient. Sometimes that feels like wanting to give the strongest, broadest spectrum antibiotic. But we need to ask, is that really the best thing, not just for this patient, but the patients in the global community? We need to carefully think about why we are giving an antibiotic, what drug we choose, and how we are using it, dose and duration of therapy. We are falling behind the curve with the prevalence of multi-drug resistant organisms and the lack of new and innovative antimicrobials. Antimicrobial stewardship is just one facet in the efforts to improve outcomes among patients with infections and reduce the incidence of resistance. Everyone plays an important role as good antimicrobial stewards.
Antimicrobial resistance is an increasing problem worldwide. WHO has already tagged antimicrobial resistance as a global concern and identified that antibiotic misuse as one of its drivers. 20 to 50% of antibiotic prescriptions are either unnecessary or inappropriate. Antibiotics are given when they are not needed. The wrong antibiotic is chosen to treat an infection. They are continued when they are no longer necessary. They are given at the wrong dose, or broad-spectrum agents are used to treat very susceptible bacteria. To define antimicrobial resistance, it is the ability of an organism to stop an antimicrobial from working against it. As a result, standard treatments become ineffective, infections persist and may spread to others. It is a global concern because it challenges the control of infectious diseases, jeopardizes progress on health outcomes by increasing morbidity and mortality, and imposes huge costs on societies. There are 3 major drivers of antimicrobial resistance. These are transmission of resistant microbes via direct contact, selective pressure from antimicrobial use in humans, and gene mutation and gene transfer under microbial exposure. So what is antimicrobial stewardship? It is the optimal selection, dosage, and duration of antimicrobial treatment that results in the best clinical outcome for the treatment or prevention of infections with minimal toxicity to the patient and minimal impact on subsequent resistance. As per JCI standard, The hospital develops and implements a program for the prudent use of antibiotics based on the principle of antimicrobial stewardship. The following measurable elements are shown in the screen. All hospitals are mandated to implement the Department of Health's AMS program. AMS shall be institutionalized and must be implemented on a national level by each country. The DOH Manual of Procedure ensures rational prescribing, dispensing, and use of antimicrobials to optimize the treatment for infectious diseases towards improving patient outcomes, reducing healthcare costs, and protecting public health. In application of the DOH AMS program, Makati Medical Center's AMS program has 6 core elements as well, namely leadership, policies, guidelines, and pathways, surveillance of antimicrobial usage and antimicrobial resistance, action, education, and performance evaluation. The first core element is leadership. This figure illustrates a multidisciplinary leadership, clinical governance, and accountability in AMS management in the hospital. In 2017, with the support of the hospital administration, an AMS committee and team were created who were responsible in implementing, performing, and monitoring the AMS program, reflecting a holistic and coordinated approach that aims to establish and sustain an effective hospital-wide mechanism of promoting judicious antimicrobial use in the hospital, thereby preventing further emergence and spread of antimicrobial resistance. The AMS team, which comprises the AMS committee, is composed of the AMS clinician, AMS officer, clinical pharmacist, and administrative staff, under which are antimicrobial prescribers and nursing and patient care services. The policies, guidelines, and pathways are the next core elements. In MMC, we have different strategies and policies for AMS. We have point-of-care interventions, which are direct feedback to prescribers at the time of prescription or laboratory diagnosis. We also do audit and feedback of monitored antimicrobials, which is the external review of individual antimicrobial prescriptions for appropriateness and feedback to prescribers as needed. We also created and disseminated clinical practice guidelines for surgical antibiotic prophylaxis or SAP, which indicate correct duration and appropriate antibiotics. We also implement restrictive interventions or policies to monitor use of different antimicrobials. These are pre-authorization and restriction, which requires clinicians to obtain approval for use before prescribing selected antimicrobials. All antimicrobial prescriptions must have written indications and must have documented review or stop dates. 7-day auto-stop for all antimicrobials unless there are approved indications for prolonged use, and 24-hour stop for SAP unless there are approved indications for prolonged use. Here's the list of the forms that need to be filled out that serve as barriers to prescribing and administration of antimicrobials. The 7-day auto-stop or request for extension of therapy form, monitoring and request for extension of surgical antibiotic prophylaxis or SAP form, antimicrobial request form or ARF for monitored antimicrobials, ARF for restricted antimicrobials, and form for IV to PO antimicrobial switch. The next core element is surveillance on antimicrobial use and antimicrobial resistance. Antimicrobial surveillance monitors resistance patterns and antimicrobial susceptibility, while antimicrobial use monitoring provides critical information on the antimicrobial prescribing or usage patterns within the hospital or specific patient groups, such as increasing use due to unnecessary surgical antibiotic prophylaxis, increasing infections, broad-spectrum antibiotics, and etc. This is an example of an antibiogram. How do we interpret it? For example, in 2019, E. coli was isolated in 776 people. It was tested against cefuroxime. Of the E. coli cultures tested against cefuroxime, 61% were susceptible to the antibiotic. In clinical practice, if a patient at this institution is suspected to have an infection due to an E. coli and the provider elects to use cefuroxime as empiric therapy, based upon this hospital antibiogram, there's an estimated 39% chance that the organism will go untreated due to cefuroxime resistance. The antibiogram is used to guide empiric therapy and to monitor antibiotic susceptibility trends within the hospital. Selection of empiric therapy in a particular patient should not be based solely on an antibiogram. A patient's particular infection history, including past antimicrobial use, must also be considered. The importance of antimicrobial stewardship in infection prevention and control department is to minimize transmission of multi-drug resistant organisms or MDROs. Once a patient is admitted to a hospital, different factors predisposes him or her to acquire MDRO colonization, which can lead to infection, increased morbidity, increased hospitalization, increased healthcare costs, and even death. AMS helps to limit the unnecessary use of antimicrobials, overtreated course, or overuse of broad-spectrum antimicrobials. The IPC will determine the compliance of healthcare workers in hand hygiene, failure to isolate patients who have MDROs, and inadequate environmental cleaning. The fourth core element is action. The actions include pre-authorization and restriction of antimicrobials, audit of monitored antimicrobials, 7-day automatic stop for all antimicrobials, 24-hour automatic stop for surgical antibiotic prophylaxis or SAP, point-of-care interventions such as dose optimization, streamlining or de-escalation, and IV to oral switch, and antibiotic prescribing, documentation, and dispensing. For Action 1, which is the pre-authorization and restriction, we have two different categories of restrictions for antimicrobials. Category 1 warrants the completion of antimicrobial request form, and criteria for use is within the pre-approved indications. Antimicrobials under Category 2 warrant the completion of ARF and requires automatic referral to Infectious Diseases Service. It is important to familiarize yourselves on the different antimicrobials and under what category they fall under. So here's an example of the antimicrobial request form, which is downloadable in SharePoint. Configuration and how to accomplish it electronically is currently ongoing in EMR. For monitored antimicrobials, there's a separate ARF that will be filled out, which is audited for appropriateness of use within 24 to 48 hours by the ID fellow or AMS clinician. The sample of the ARF form is seen on the left of the screen. The monitored antimicrobials is listed on the table on your right. Currently, this is already configured in the EMR. For monitored antimicrobials in the EMR and dashboard, you can see here that it is already configured, and I will teach you on how to fill out the form. A mandatory form is accomplished by a clinician when a monitored antimicrobial is prescribed during admission or ED consult. A monitored antimicrobial is dispensed by the pharmacy services only upon completion of ARF for monitored antimicrobials, and this form is audited by the AMS clinician or ID fellow for appropriateness of use. It can be seen on the EMR Antimicrobial Stewardship tab under the Services option. For adult patients, you must select Dr. Maria Tarcela Glaire, and for pedia patients, you must select Dr. Robert Dennis Garcia. You must click the CPOE or the Referral tab because you need to refer the patient to EMR Antimicrobial Stewardship for adult and pedia AMS clinicians and ID fellows to view and access the patient's medical records. The ARF is found in Forms and Attachments tab, then you should select New. In Favorites, you must search for the document which is the AMS form, and it will show the antimicrobial request form for monitored antimicrobials. So in here, we can see that the ARF form is configured in EMR. It is important that you must fill out this form completely. On the lower part of the ARF is the audit and feedback, and this is only to be filled out by the AMS clinicians or approvers only. So here is a sample output of the ARF in EMR. This can also be accessed in SharePoint. The pharmacy, nursing, and AMS team can monitor the ARF for the status of the antibiotic request, whether approved or not, and for AMS clinician or approvers to see if they have pending approvals. Action 3 is the 7th-day auto-stop or SDAS. A treatment period of up to 7 days is given for all antimicrobials, after which an automatic stop procedure is enforced unless there are approved indications for prolonged use. The following are the indications with approved prolonged use which are not subjected to SDAS review. So here is the sample form for 7-day automatic stop. Surgical antibiotic prophylaxis or SAP has become the standard of care for contaminated and clean contaminated surgery and for surgery involving insertion of artificial devices. SAP must be given as a single dose within 1 hour prior to surgery, or for vancomycin and fluoroquinolones, 1 to 2 hours prior to surgery. Surgical antimicrobial prophylaxis must be stopped within 24 hours. All surgical antimicrobial prophylaxis may be dispensed within 24 hours, after which an automatic stop is enforced. If the duration is beyond 24 hours, prescriber must accomplish a monitoring and request form for extension of SAP and seek approval from AMS clinician or ID fellow. Only approved doses will be dispensed by the pharmacy services. Timing is crucial in surgical antimicrobial prophylaxis. As agreed during the previous SSI meetings, due to unexpected delays of surgeries, SAP must be administered upon induction of anesthesia. A single dose of antimicrobial with a long enough half-life to achieve activity throughout the operation is sufficient for prophylaxis under most circumstances. Post-procedure doses are generally not needed, and there is no added benefit obtained from multiple doses. Inappropriate use of antibiotics for SAP increases both cost and the selective pressure, favoring the emergence of resistant bacteria. The recommendations for SAP are lifted from the WHO and CDC guidelines, along with the guidelines of other international societies. Streamlining or de-escalation of therapy entails adjusting empiric antimicrobial regimen to targeted therapy or culture-directed therapy, discontinuation of empiric antimicrobial therapy when investigations fail to demonstrate evidence of an infective process, and discontinuation of redundant concurrent antimicrobials. All empiric antimicrobials shall be reviewed in a timely manner 48 to 72 hours after the start of therapy for the possibility of de-escalation. Here is a diagram of procedure for streamlining or de-escalation of antimicrobial therapy. We can see here that obtaining a microbiological culture is important if ever possible before the initiation of an appropriate empiric therapy. The attending physician monitors the patient's clinical status response and results of microbiological and other tests after 48 to 72 hours to see if the antibiotic should be continued or shifted to an oral regimen. Ideally, it is important to obtain cultures before initiating antimicrobials for the following reasons. Number 1, to improve the chances of identifying the offending organism. Number 2, obtaining cultures after antimicrobial therapy has been started can cause inconclusive results because organisms that would otherwise be detected may not necessarily grow after exposure to an antibiotic agent. Number 3, administration of antimicrobials before culture collection may decrease culture yields. And number 4, it is more difficult to de-escalate therapy without cultures. The next point of care is dose optimization. It involves optimization of antimicrobial dosing based on patient's characteristics, causative organism, site of infection, and pharmacokinetic and pharmacodynamic characteristics of the drug. The pharmacist review and assess all medication orders, including antimicrobials, before dispensing. The pharmacist checks for correctness and coordinates with the prescriber for any suggestion on the following. Going to the IV to PO switch, all patients receiving IV antimicrobials with excellent oral bioavailability for indications that do not necessitate prolonged IV therapy shall be assessed for switch to PO therapy. However, there are also indications for prolonged IV antimicrobial therapy, which are the following diagnoses listed on the screen. So here is an algorithm showing the procedure for IV to PO switch. The first criteria is clinical stability, wherein the patient is febrile, with downward trend or normalization of quantitative CRP or WBC count, and a stable vital signs. The second criteria is the ability to tolerate oral intake, wherein the patient is not nil by mouth, tolerates oral diet, medication, and enteral feeds, and oral absorption is not compromised. Patient should have no vomiting, diarrhea, or malabsorptive disorder. Action 6 is quality indicators for antibiotic prescribing and documentation. For the first hour, give antibiotic for sepsis immediately. Obtain necessary cultures first prior to antibiotic administration in the absence of sepsis. Take and document history of allergy to relevant agents. Write indication, route, and intended duration upon ordering antibiotics. Narrow-spectrum antibiotics should be prescribed in preference to broad-spectrum agents where appropriate. Antimicrobials are given orally rather than IV if possible, and relevant treatment guidelines should be followed. After 24 hours, document or auto-stop SAP for all procedures except for cardiothoracic procedures, which can be given for 48 hours. After 48 to 72 hours, assess the need for antibiotics by reviewing pertinent labs such as culture results and procalcitonin, then document. On the 7th day, stop antibiotics for most infections and document plan. So here is the summary of actions in AMS treatment algorithm. The fifth core element is education. The Patient Safety Skills Essentials on Basic Infection and Control aims to teach all health professionals the necessary principles of judicious prescribing and use of antimicrobials. Education of all healthcare professionals on the principles of judicious use of antimicrobials is necessary to enable positive behavioral change. For education, we do AMS Roadshow, lectures, and orientation. We also have information, education, and communication materials for staff, visitors, patients, and relatives. We provide brochures and leaflets to patients and relatives. And we also post an AMS exhibit board and posters on each floor. To prevent and control the spread of antibiotic resistance, health professionals can do the following. Prevent infections by ensuring your hands, instruments, and environment are clean. Only prescribe and dispense antibiotics when they are needed according to current guidelines. Report antibiotic-resistant infections to surveillance teams. Talk to your patients about how to take antibiotics correctly, antibiotic resistance, and the dangers of misuse. And talk to your patients about preventing infections. The last core element is performance evaluation. Program performance evaluation is crucial in guiding the progressive implementation of the program and tracks the progress of the annual AMS program monitoring report. Process and clinical indicators are also measured to assess the overall quality management improvement and effectiveness of AMS interventions, which is fundamental in guiding the progressive implementation of the program towards achieving the goal to combat antimicrobial resistance. Here are the references used for this presentation. We must always remember that if there is no action today, there is no cure tomorrow. The goal is to combat drug resistance. Thank you and have a good day.